So the background specifically is that the standard of care for renal cell, at least for advanced renal cell carcinoma, has changed since 2005. Obviously, with the recognition that inhibiting the VEGF pathway actually turns out to be actually probably the most important therapeutic experience that we have encountered in renal cell carcinoma since the approval of sorafenib, sunitinib, and so forth throughout the last 10 years or so. The difference right now is that the standard of care for many years has been TKI therapy as a frontline treatment, but the sequence, the appropriate sequence for our patients is really not well defined. So we have frontline agents, we also have second line agents, right? And so far, to the extent of the data we have demonstrated that the standard frontline agents are sunitinib or pazopanib. And then when you move from that therapy to second line therapy, then the questions were between, did you do another TKI or did you switch mechanistically from a TKI to an mTOR inhibitor? So to that end, axitinib is another TKI, also a VEGF inhibitor that was approved in the second line space based upon the AXIS data. And everolimus prior to that had also FDA approval in the second line space, after a TKI refractory disease. Over the last year or so, perhaps since November 2015, obviously with the approval of nivolumab, now the standard of care changes again. Nivolumab got approved after primary therapy in patients who have failed TKI therapy and move on to second line. And for the first time ever, we have survival data. That data we didn't have before with any other TKI. So nivolumab was the first agent in the second line space demonstrating survival benefit. And now with cabozantinib, yet again, we have another agent that is able to demonstrate survival improvement in the context of second line therapy. And so that's the METEO data, which is the data that was actually published last year, back to back with nivolumab in the New England Journal of Medicine. And about a month ago or so, got finally registration in the United States based upon that data. So METEO was a randomized phase 3 trial that looked at 658 patients plus, randomized them to either cabozantinib, a standard dose 60 milligrams daily, or the historical control everolimus at 10 milligrams daily. Patients were randomized 1-to-1 to both agents. And the important part of that is that patients needed to have failed one prior TKI, or at least one prior TKI. I shouldn't say one only. Many patients actually had seen second lines as well. And the primary endpoint of this trial was actually powered for progression-free survival with a secondary endpoint of survival. So what was presented last year and what was published last year in the New England Journal was the PFS data and demonstrated that using cabozantinib you can delay progression compared with everolimus. But the survival data wasn't actually mature yet. So what Dr. Chari presented today at the meeting was actually the final survival analysis for that trial. And basically the three key points are progression, survival, and response. So with regards to progression, treatment with cabozantinib had a median progression-free survival of 7.4 months compared with 3.9 months for everolimus, a hazard ratio of 0.51. That means that you have a 49% relative risk reduction of progression if you receive cabozantinib. When you look at the survival data, survival with cabozantinib was 21.5 months or so, whereas the median survival for everolimus was around 16.5 months or so. Yet again, a hazard ratio of 0.66, indicating a 34% relative risk reduction in mortality if you receive cabozantinib. And when you look at the response rate, obviously traditionally mTOR inhibitors don't really lead to great responses. Not surprising, the response was less than 5% for everolimus, and for cabozantinib treated patients was 17%. So if you look at the three key elements for efficacy, survival, PFS, and response, here we have a very effective and powerful agent. The difference between cabozantinib and the other TKIs is that cabozantinib not only is a VEGF-R2 inhibitor, but also is an inhibitor of MET and AXL, which are actually molecules thought to be related with resistance from prior TKI therapy. So there is a class effect of side effects that patients experience when they receive a TKI. So no different than the previous TKIs, cabozantinib also have those side effects. Hypertension, hand-foot syndrome, diarrhea, and fatigue perhaps is the biggest side effects that one may encounter with cabozantinib. And I think that is very important for whoever is going to start using these agents to understand how you maximize quality of life and minimize those side effects. In the METEO data, 60% of the patients required a dose reduction from 60, most commonly was 40, and 20% of patients received the lowest dose of cabozantinib, which was 20 milligrams per day. So clearly, although you do see some toxicities, it is important to recognize that you have to manage those toxicities if you want to continue the patient on therapy. Otherwise, patients may encounter side effects that obviously will actually lead you to abort the treatment. The take-home message for us is that for the first time in renal cell carcinoma, at least in 10 years, for the last 10 years since we approved the first VEGF inhibitor in 2005, is then we have two agents that actually lead to survival improvement in the history of renal cell. We have never seen that before. So first with nivolumab and certainly with cabozantinib, yet again another oral agent that actually is able to demonstrate survival benefit. So I think that now the bar has actually changed for us. It's not PFS what is important anymore in renal cell carcinoma, which was the endpoint that we utilized for the most time to registration strategies. Now is survival. So all the endpoints to some extent in renal cell carcinoma will have to change and will have to actually be survival as a primary endpoint.